I'm Rochelle. I'm the Senior Speech Pathologist for ADAC in our Far West Murrumbidgee district, and I'm based in our Griffith office, which is about 6 hours drive west of here, but I caught a plane, so it's fine. I developed this presentation today with the help of Priscilla DeMarco, and she's also a speech pathologist in our office in Griffith. Now, she would have really loved to come today to present as well, but she's about to have a baby, so she's a little bit busy with that at the moment. Now, I know that there are some people here with a huge amount of experience and knowledge about working with people with intellectual disabilities around mealtime management. And I know that there are some people here who are new to this topic of speech pathology and some people who are students, so new to speech pathology in general. So I guess I've tried to get a little bit of a balance here, and I'm not really here to tell you how that you should assess or manage mealtimes with your client base, but I guess I'm just going to talk a little bit about some of the literature and about how I've worked with people and a few different things to think about when you're considering assessment and management of people with intellectual disability in mealtimes. So, there we go, it worked. Evidence-based practice. So ADAC really encourages us to use this framework by Hoffman, Bennett and Delmar to underpin our practice. So if we think about evidence-based practice, it's more than just reading journal articles or considering high-level research. It's about drawing upon your own education and clinical skills and experience and combining that with a client's circumstances or situation or values and putting that together within the practice context in which you work. So resources, funding, service delivery models. Now, when working with people with intellectual disability, we know that our assessment and intervention needs to be person-centred or family-centred. And we also know that it's best practice to provide assessment and intervention options within the client's natural environments. Mealtimes don't exist in a vacuum or in a clinic room, so we need to be considering the person in the context of their home or school, their work, their day placement, their community, anywhere that the client lives their life. Now, the other important thing around evidence-based practice for people with intellectual disability includes functional goal setting. So we need our goals to be functional in order for them to be effective, particularly around mealtimes. We know that we need individualised outcome measures, and the examples I've got up here, the GAS and the COPM, so goal attainment scales, or the Canadian Occupational Performance Measure, and there are links to those in your resource lists. They're just a couple of examples of outcome measures we can use. Now, the other big thing that we know is really important is being able to work collaboratively as part of a team. Now, I know there is absolutely no way I could provide mealtime support without the input and experience of the rest of the team I work with. It would just be too big and too hard. So I know as well that some of you will know the ICF model back to front. You could recite it all to me in your sleep. But I thought it was still important to put up here because we can use the ICF as a framework to underpin our clinical work, particularly around assessment at mealtimes. So historically, if we think about dysphagia, there's been a really heavy focus on the body structures and functions component of the ICF. And there's been a bit of a move towards assessing our activity and participation domains, considering things like social life restrictions or the time it takes to eat your meal or going out to eat. But there has been not a huge amount of focus on the personal factors or environmental factors when you're sort of considering how we've traditionally looked at dysphagia assessment. But these are the ones that significantly contribute to our overall mealtime experience. Now, today, while there is some focus on the body structures and functions in my presentation, because that is really important, a lot of the time, the areas where we can make the most difference or make the most change to achieve positive mealtime experiences is if we focus on the activity, participation, and environmental domains of the ICF. Now, what do we already know? I'm in a room full of speech pathologists, so I assume that you know a lot. We swallow food, drink, medications, secretions. We swallow all day, about 900 times a day, which is about 900 opportunities for our swallowing to go wrong. We know that swallowing is complex, and we know that disability is complex. But who doesn't love a challenge? Let's just combine the two together. The important thing to think about around mealtimes is that they're multifaceted, but also we need to consider that swallowing is more than just mealtimes. We talk a lot about client risk around dysphagia, so choking, asphyxiation, aspiration, malnutrition, dehydration, physical health needs. But the other really important part is that social side of mealtimes. And the thing is, we want to make a difference. We really do. We want our clients to enjoy eating and drinking, and we want our clients to be comfortable at mealtimes. We want that social communicative interaction for them. We want our mealtime partners to be able to engage positively with the people they support. And we want celebrations to feel celebratory. We want to make a difference. And so let's talk a bit about how we can make a difference to these people throughout our assessment. So you receive a referral through whatever process occurs in your workplace, and you see that it's for a person with an intellectual disability. What kinds of things might you need to do to prepare for the assessment? Who can you speak to? Who knows the person well? What's the best time to see the person? Now, the next couple of slides, they're just a few things to think about maybe in preparation for the assessment. And I'm not going to read out everything because you can look through them later, and you can probably see that I've got a mountain of slides to get through and not that long to speak, I suppose. So a couple of things to think about. When you're assessing someone in their natural environment, what's the best time to go? What do you need to take along with you to the visit? Will you need to trial thicken fluids? Take some thickener. Will you need to trial different mealtime consistencies? Take some puree, something that's minced moist, some dissolvables. How does the person communicate? Will you need to take some visual supports to facilitate your assessment? More times than I'd like to admit, I've organised to review someone's swallowing at lunch, and I've turned up to their home at a specific time only to have the support worker say, "Oh, well, I mean, he was really hungry before, so I already gave him his lunch. I guess I could give him something else if we really have to." Not that helpful. It's really important to be able to work collaboratively with the support workers or family members to ensure that they understand why a mealtime assessment is important, and to make sure that they wait for you to get there before offering the person some food. And I guess this is about a bit of give and take, maybe make your mealtime assessment at the time a person typically eats, make sure you're on time, but also encourage them to not start before you're there. So often if I'm calling someone on the phone, I always double check before I hang up. Now, you've written in the communication book, you've written in the diary, don't feed Adam till Rochelle comes. She'll be there on time, but don't do it. I guess a few other things to think about are what's a typical mealtime for the person. We need to structure our assessment around that time, and routine can be really, really important for some of our clients. An assessment where someone is really hungry or when they're not hungry at all isn't actually going to give you a great clinical picture of what they're like during a typical day. And I guess the other big thing on this slide that I think about is about risk assessment. So we need to make sure that we're considering risks for the client around that mealtime, but also considering risks for the other people in the house or for us as well. So we've got our referral. Let's have a bit of a look at our, I skipped that one, case history. We know that people with intellectual disability have a shorter life expectancy and are at a greater risk of early death than the general population. We also know that people with intellectual disability present with more frequent health issues than their peers, and this is partly because of a biological predisposition and partly because of social and economic inequalities. Now, in a 2008 study of a bunch of English adults with mild to moderate intellectual disability, these people rated their health as not good. 1 of 8 of those people rated their health as not good. And I guess the authors of this study outlined that this is probably an underrepresentation of the health status of this population. So we know, from research that clinically the health status is lower, but also people with intellectual disability are identifying that they don't think their health is as good as the rest of the population. And if we think about things like respiratory disease, coronary disease, dementia, epilepsy, vision impairment, hearing impairment, physical disability, mobility difficulties, reflux, osteoporosis, mental health, oral health, there's all these different areas where we know that people with intellectual disability are at a lower level than the general population, and that's kind of the background to why our case history is so important, because we've got this client group that is a bit more at risk. Now, we also know that very few people who present with dysphagia do so in isolation. And if we think about people with intellectual disability and all the health issues that we just listed, we know that they can all impact swallowing in a bunch of different ways. So to obtain a clearer picture about what we're assessing or what we need to address, we really need to have as much information as possible, and a thorough case history is one of the ways that we can do that. Now, I guess a couple of things that we really want to include in our case history: confirmed diagnostic information, not just what someone thinks a person's diagnosis might be. So I did work with a teacher once who spent a lot of time telling me, "Oh, James, he's so autistic," or "That's just James's autism," or "Oh, he only behaves like that because of his autism." If I didn't look any further into James's case history, I might have thought he had autism when he actually didn't. I might have targeted my assessment and intervention very differently. So our case history, we want confirmed diagnostic information, we want information about someone's medical history, previous speech pathology involvement, what other health professionals are involved, medications, respiratory health, history of chest infections. We need to consider a person's cultural and religious background, their weight history, have they had weight loss, weight gain, is their weight been fairly stable, reflux and regurgitation, allergies to food or fluids or medication as well. What's their vision and hearing status like? What are their sensory preferences, communication skills, cognition, behaviours of concern, mental health, physical positioning, mobility needs. We want to know about the best environment that the person eats in, the worst environment the person eats in. We want to know about the foods they eat really well and the foods that are really difficult for them, the things they really like and the things they really don't like about mealtimes. We want to know as much as possible, as early on as possible, to facilitate planning and appropriate assessment. Now, I was a few months ago referred a man who presented with quite significant regurgitation and rumination, and as a result, significant weight loss as well. And I was questioning the function of the pharyngeal phase of his swallow and concerned about esophageal injury around the regurgitation and rumination. When I spoke to the team about this man accessing a modified barium swallow or video fluoroscopy, I was told, "Oh, yeah, he had one of them. It wasn't that long ago. It all came out clear." I said, "Great, that's wonderful. Can I see the report?" His parents were really opposed to any kind of repeat assessment because he didn't really enjoy it the first time. But no one could find the report or any kind of documentation around this. It took me about a month of harassing people to figure out that this client had had a barium meal, not a modified barium swallow, and we didn't actually have the information we needed about the pharyngeal phase of his swallow. So it's really important to figure out what's happened before so we can plan what we want to do in the future. Now, we know case history is important. We know that we need to collate a lot of information from a lot of different people, files, records, to build up a comprehensive picture of the person. And we know that it takes time, but it's really important to be able to factor in that time. Mealtime management is more about addressing dysphagia, and positive mealtime experiences are about the whole person, their whole situation, their life. This is somebody's story, and it's important that we can show respect to that person by allowing them the time to tell their story. Because I guess you can see someone at a particular point in time, maybe across a few contexts, maybe across a few months, but you don't really know their whole background just from that interaction or how they present all the time. And I guess the other really important thing to remember is that you can do the most thorough, amazing, comprehensive case history that doesn't prepare you in any way for how the person presents on the day that you show up to see them. So, a couple of things to think about with your case history. I think the big one here is about asking the right questions. Make sure you're not using your speechy lingo, and have a think about, the difference between asking, has Gabby had any respiratory health issues in the last 12 months, compared to, so has Gabby taken any antibiotics recently? Oh, she has. What were they for? They were for a cold. Great. When was the last time she took antibiotics for a cold? How many times do you think she's taken antibiotics for a cold this year? Was she on antibiotics near her birthday, around Easter, over Christmas? It can sometimes be really helpful to frame your questions around specific events. And I guess the other side of that is about educating after questioning. So explaining to Gabby's carers the impact of her taking so many antibiotics for a cold or a chest infection, and how that might also impact her swallowing or mealtime presentation. Now, I thought I'd put together a bit of a list of barriers and solutions for the different components of the assessment, and you've got them all in your handouts there. Now, the lists aren't in any way exhaustive, but just a few things to consider when working with people with intellectual disability. I'm not going to read these out as we go through, but find me at lunch or morning tea if you have any questions, or if you have any better solutions, definitely come and find me. So, communication. We know that communication is a basic human right, and we know that as the complexity of disability increases, so does the complexity of a person's communication needs. Now, a room full of speech pathologists knows that everybody communicates. Everybody falls somewhere along this continuum of communication, and the difference between these sections is really how much your communication partner needs to interpret or assign meaning to the communication attempt. Now, one of my absolute pet peeves is when a carer or support worker or teacher or therapist or doctor says, she doesn't communicate. Well, there's so much more to communication than just words, and I've never yet met a person who doesn't communicate. Now, we know that best practice dysphagia management includes consideration of a person's communication. That's in the SPA dysphagia guidelines. And specifically, when working with a person with intellectual disability, communication is really important to consider around things like consent, pleasure, pain, discomfort, or just to comment on your mealtime experience. Effective communication is also really useful to be able to develop rapport with people, and we know that our client group, people with intellectual disability, often present with complex communication needs, and developing rapport might be different to the way you might need to do that in the typical population in a hospital setting or a paediatric community health setting. Recently, I received a immediate response referral for a woman who lives about 3 hours drive from where I live. I did all my prep, gathered my equipment, hopped in the car the next day, and then I met this woman in her home. And the support workers who were there said, look, she can be really standoffish around strangers, just maybe step back a bit. I said, okay, what kind of activity, what can we do together that she really enjoys and she won't mind if I join in as well? The support worker suggested that maybe we play the keyboard together. So Sarah and I played the keyboard, and while I'm not convinced she enjoyed my musical skills, it was a really nice way to allow her to get me used to just being near her, touching her hands, touching her arm, just being nearby. And so when dinner was ready, she was really comfortable with me sitting nearby, having a look in her mouth, interacting with her. And her support workers commented and said, look, the fact that you've spent some time with her meant that she was a little bit more comfortable. We've made this mealtime assessment go a little bit more smoothly. I guess it's about taking the time to develop a bond with someone, and this not only allows for an effective mealtime assessment, but also reinforces the importance of mealtimes as a social experience. Some things to consider around communication in mealtimes. We know that communication can play a huge role in the overall mealtime experience, and addressing communication needs can sometimes also facilitate increased safety when eating or drinking or taking medications. Now, Sarah, who I was just speaking about, she was referred because she was coughing and choking at every mealtime. She'd been prescribed a puree text-to-see diet, and she'd been tolerating it well up until recently. She didn't have any formal communication system in place. She understood some keyword sign, but it was a little bit hit and miss. So when it came to dinner time, Sarah fed herself independently, and the first half of dinner she had no difficulties. Things were great. I turned to speak to a support worker, and of course that was the point where she decided to cough and choke. So she dropped her spoon, the support worker went over to her, gave her a bit of a break, and comforted her. Now, she had a bit of a break from dinner, and then we re-offered her the dinner. I was keeping a bit of a closer eye this time, thinking, what did I miss? She took one spoonful and then started to push her spoon further down her throat. And the support worker said, oh, yeah, she does that sometimes. We don't really know why. And that was when we kind of went, oh, maybe this is more than just a swallowing issue, but also a communication issue. And then what I learned was that Sarah prefers her meals to be warm. When she chokes on her spoon, her cold meal is taken away and she doesn't have to eat it anymore. All we did was place a really simple visual communication board in front of her. So too hot, too cold, I'm finished, I'm happy, just next to her bowl. And within a week, she was really effectively using that communication board to point and say, nope, you need to warm up my dinner again. Obviously, this quick communication fix isn't going to work every time. But with all mealtime assessment and intervention, we really need to look past what is obvious, so the choking, and have a little bit of a further look into other relevant mealtime components, so around communication. Now, again, barriers and solutions. Another point I don't have on your slide is that it's okay to not understand what someone says. But I think having some appropriate strategies to request clarification is really important. So I was working with this man fairly recently, and he was moving from his current home to a new group home about 2.5 hours away. He was really concerned that the people in his new home, so his housemates or his support workers, wouldn't understand what he was going to say. So we decided to work together to come up with some strategies that everyone else could use to help understand him. And so the strategies he came up with were, you could ask him again, you could ask, or you could try to guess the word or guess the topic he was talking about using the context. You could ask him to point or gesture or show someone else, or you could ask him to tell someone else. Maybe they would understand a little bit better than you. And these strategies for this particular man, they worked really well. They won't work for everyone, but I guess the point here is that it's important to involve the person you're working with in the process of identifying what does and doesn't work for them. Looking to the environment now. So I've already mentioned that to get a comprehensive picture of the person, we really need to assess them in their natural environment. But in doing this, we also need to be sensitive and respectful. You're a visitor in somebody's home. This means that you might also need to assess them in all the places they eat and drink. So they might be at home, but where do they have their meals? So do they sit in their wheelchair, or do they sit in another seating system at the kitchen table? Do they ever have medications in bed, for example? Or are they ever having a cup of coffee sitting on the lounge chair? When we look at the mealtime environment, we start to realise that it's a really big thing to consider. And when your mealtime environment, so community areas, cafes, schools, restaurants, day placements, when they can be, there's lots of people there, they can be quite chaotic. It's not really a surprise that people with intellectual disability and dysphagia have difficulties eating and drinking in those environments. Now, the general rule, I guess, is that as the environmental complexity increases, it might be necessary to reduce the complexity of the mealtime tasks. So downgrading textures, increasing positioning support, increasing supervision or physical support for the mealtime. Having a look at our environmental considerations, we need to really look at distraction, is the person comfortable, their sensory preferences, and what is and isn't a typical mealtime environment. The fact that we're already there in someone's mealtime having a bit of a look means that it isn't a typical mealtime environment because you're not there every day. You need to consider how you impact the environment or the person's mealtime experience. I was working with a man recently with diagnoses of intellectual disability, autism, and bipolar disorder, and I took a student with me to the mealtime assessment, and we met this man at his day program. He was settled at the table, things were okay, but each time one of us got up to move closer to him to assess his swallow, he became a bit agitated and pushed his chair back from the table and started to leave. And at first I thought, oh, okay, maybe he doesn't want people near him, that's all right. But he was okay when his support worker went over to him or moved towards him. And then I thought, all right, well, maybe he doesn't want unfamiliar people near him. Although I had worked with him before, and roughly I would see him at least once a week at day placement or at home, just incidentally. So I guess we looked toward the environment. Now, this dining area had wooden floors. It was really echoey and really noisy when I walked towards him with my loud shoes on. Wasn't noisy when the support worker walked towards him wearing her sneakers. So, took off my shoes, was able to continue the assessment. Now, I'm not really recommending you go to work without shoes on, but I guess just be aware that what you wear can really impact the mealtime environment of the people you work with. So noisy shoes, jangly jewellery, a long flowy scarf, your perfume, that can all play a role in the mealtime experience of that person. Now, I'm probably going to repeat myself a couple of times this morning, but mealtimes really are a social experience, and effective mealtime support can contribute to a positive mealtime experience for the person. Introduce yourself, tell them what food or drink is on offer, give them a choice about the food and drink, orient them to the food when it's ready to eat, communicate about their day. Just some really important points for mealtime partners to consider. Now, a couple more things to think about. When we're assessing someone in their natural environment, think about those things like distractions. The lights, are they on? Are they off? Are they flickering? Are they making that annoying buzzing noise? Music, TV. Is there someone mowing the lawn outside? Is there a dog barking? The smell of the food, the smell of the bathrooms. Are there people talking or singing or making noise in the mealtime environment? What's the temperature of the room? Is it too hot? Is it too cold? And where is the person sitting in relation to other people? Is their back to the wall looking out at the room, or is their back to the room? Do they try to look around or turn to see other people, or do they prefer reduced visual distraction? All these things we kind of need to be considering as we go on. And then there's our list of barriers and solutions, which I'm just going to skim right across. Mealtime partners, the other big thing. So within our mealtime environment, we need to pay particular attention to the mealtime partners, and we know that lots of people with intellectual disability need additional support at mealtimes. We also know that mealtime dependence is one of the strongest predictors of choking and aspiration pneumonia. So that Langmore article, the reference up there, identifies mealtime dependence as a stronger predictor than previous diagnosis of dysphagia or previous aspiration documented through instrumental assessment. So mealtime partners play a pretty significant role in the person's overall mealtime experience, and mealtime partners can really make a difference. It's important that the mealtime partner is familiar with their role, that they know the person's mealtime needs. Positioning of the mealtime partner is really important. They need to be comfortable and relaxed and available for the person they're feeding. They should sit opposite the person at their eye level. You don't want someone to be sitting down ready to eat and someone standing on top of them trying to feed them from a higher position. A positive relationship between the mealtime partner and the person they're supporting can really make or break a mealtime experience, because mealtimes are social. Recently, I was working with a man who needed quite a lot of physical support to eat and drink, and I was observing his meal times with 2 different support workers one evening at dinner. So this man has his meal split up into 2 sections over dinner, just to give him a bit of a rest in between. Now, the first support worker that did the first half of dinner really hurriedly tied his bib on, started rapidly spooning food into his mouth, while she was also keeping an eye on Deal or No Deal on the TV. She didn't watch the food spilling back out of his mouth, and when she did notice excess food on his bib, she was a bit annoyed at the mess that she'd have to clean up. And this client started to breathe really rapidly, his eyes were watering, he was becoming a bit upset, and so then she stopped the meal saying, "Oh, no more for you, you'll just have to wait for the rest." He did have a rest, thank goodness, and the second support worker came along and he repositioned this man before starting the meal. He turned off the TV. He spoke with this man about what he was eating, and he spoke to me about what he does to support this client. Now, the support worker showed me that he waits for David's Adam's apple to go up and down twice before he gives him another spoonful, and he checks his mouth is empty before offering any more. And he showed me that sometimes David breathes a bit inconsistently, so he waits until his breathing sort of has stabilised before offering him any more food. Same group home, same mealtime, but 2 really different mealtime partner experiences, and I definitely know that I would prefer the second option. Now, the next presentation, Kate's going to talk a little bit more about mealtime partners and implementation of recommendations. But I guess the important thing to note is that effective implementation of mealtime recommendations is really important, and we generally have a fairly low compliance by mealtime partners. But we know that that mealtime partner experience can really make a significant difference. So some other things to consider. Some of these are systemic issues, which are often beyond our direct control, but really important to acknowledge and raise. So how many other people does the mealtime partner need to support or supervise during the mealtime? What other organisational pressures do they have? If the mealtime partner is meant to be supervising 4 other people at the same time, how effective can they be with this particular person that you want to assess? And a few other things. So again, our barriers and solutions. One barrier that I've come across fairly often with people with intellectual disability who have a high risk of penetration or aspiration is that mealtime partners can feel really anxious about feeding that person. The mealtime partner might be concerned that they're not providing the correct support, and probably quite anxious that the person will cough or choke or aspirate on their watch. Any slight movement or noise from the person they're supporting makes the mealtime partner really jumpy, and then that makes the overall experience of that mealtime really tense. Now, I don't have any amazing solutions, just further education, I guess, and acknowledging that, yeah, this person is at risk, but we also have some strategies in place to manage this risk, and having a calm mealtime partner, a calm mealtime environment can really facilitate that as well.